You ready, Holly?
I'm ready. Thanks.
Okay, good afternoon, everybody. I'm Barry Buchanan. I am the chair of the Stakeholder Advisory Committee and also the chair of the Whatcom County Council's Criminal Justice and Public Safety Committee. Welcome today, SAC meeting number 2. I'd like to call this meeting to order. We're going to get right to it because there's a lot going on. So Holly, I think you were next to do an agenda review and just kind of some rules of the road.
Great. Thanks, Barry. All right. So next slide, please, Jackie. And welcome, everybody. Here we are at the meeting number 2 of the Public Health, Safety, and Justice Facility Needs Assessment meeting, also known as the Justice Project. My name is Holly O'Neill, and I'm serving as your facilitator today. And I have with me Marty Solomon, who's going to be taking notes for us. And we have an incredible lineup today. I'm super excited for this agenda. So let's flip to the next slide and we'll go through what the plan is. So just to put a little context around our work today, our first meeting was back on January 20th of this year. And then today we're going to be looking at the criminal justice data in June. So make sure you've got this marked on your calendar for June 8th. We're going to look at the data related to behavioral health. And then we'll start, if we're ready, we'll start moving into a discussion of facilities and then the preliminary needs assessment. So these are the meetings. I have a feeling it is likely we will have 1 or 2 more meetings in this, but this is the basic construct of where we are right now. Next slide. All right, so here is our agenda for today. Barry is going to introduce our panelists, and then we have Caleb Erickson, Jeremy Morton, and Dr. Alexis Harris are all going to present some really fascinating data for you on the criminal justice system. We'll have time for questions and answers, maybe take 15, 20 minutes for that, and then we'll move into an open discussion. So really hearing from all of you who are on the SAC, your impressions of what you're hearing so far from the data that's been presented, and just from any of the other meetings you've been attending or conversations you've had with anybody you've talked to in the community. And then we'll wrap it up. So we've got 2 hours in total, and it's going to be fun. Next slide. All right. So if Alexis is there, Alexis, are you there?
Holly, I'm going to go ahead and introduce who our presenters are going to be.
I'm sorry.
That's kind of the next thing. And also,
You're
I'd like
right.
to ask, if you haven't done so already, SAC members, please rename yourself as your name and SAC member rather than just SAC member. It helps us take attendance. Okay, so today we have 3 presenters and a host of other folks that went in on the effort to put this together. Dr. Alexis Harris from the Sociology Department at the University of Washington was kind of one of our mentors through this, and she'll be talking a little bit about kind of what we can expect to hear, and then kind of sum it up at the end. Caleb Erickson, Lieutenant Erickson from the Corrections Office, will be talking about some data, and Jeremy Morton from Whatcom County EMS. He is the data analyst for the EMS, and he's done a lot of real, some of the nitty-gritty work on this data collection and analysis. So those are our presenters today. And so back to you, Holly.
Great, thanks. All right, next slide, please. So the goals of this meeting are to explore the kinds of data needed for the needs assessment and to begin thinking about how the data is going to help us arrive at our recommendations. And on the next slide, go ahead. These are all of our SAC members, and I just wanted to give a special welcome to, we had 2, if you remember, we had 2 slots to fill. So RB Tewksbury, welcome, glad you made it, and Peter Frazier, our 2 new folks. And then I'm so happy that we have Erica Lautenbach from the health department, who is going to be stepping in as the rep from the health department, replacing Jackie Mitchell. So welcome to all of you. Glad you're here. Okay, and I think we're ready to get going. Next slide.
Hi, everyone. I think I'm stepping in to do this slide. And just so some of you who don't know who I am, I'm Alexis Harris. I'm a professor of sociology at the University of Washington, and I've been working in conversation with a number of amazing people about talking through the key issues. So my research area is the criminal legal system and monetary sanctions. So I am here just to help facilitate the conversation and provide some framework to the different pieces that we'll be talking about. The aim of the conversation today is really to discuss the needs of your community regarding public safety and wellness. And you will see an amazing detailed presentation of data of what we do know and what's available so far in understanding the needs of community safety and wellness in Whatcom County. And then after the presentation of data, we'll have a discussion of remaining questions that you might have. Are there data to answer these questions, or are there other types of processes that need to be established to collect more data in the future? Could you do the next slide, please? I think Jeremy's going to step in and do this one.
My name is Jeremy Morton, and I'm the Whatcom County Systems Analyst. I support the specialized crisis programs as well as other units. I'm an informaticist by trade. Some of the preview take-home points from this process thus far is that these systems are complex. The interaction between the justice, medical systems, and emergency services are not well understood at the global level. This work that has been done by the Specialized Crisis Program has given us some insight into what's going on inside of the county, but is not represented in the picture. And then while we are looking at this very small bit of information, we do realize that we're able to expand our body of knowledge by going and gathering information from various sources so that we can transition into information that we can use to make informed decisions across the entirety of the county. Currently, what is in process is the combination of multiple systems and being able to report out of them in kind of a systematic and consistent way. This work is new in both this county as well as the United States in general. Next slide, please. So some of our obstacles are that most of the systems we're talking about evolved in their own silos. While they interact with one another, they're never designed to work together. So a lot of the vocabulary and metrics that go into these systems are going to take a lot of sorting out. And we'll get into the kind of semantics of that later on in the presentation. But note that it's not anyone's fault in that these systems are designed and behaving exactly as they're to work. It's an analogy we use a lot of the time, saying that, you know, this toaster makes a terrible martini. And there's this moment like, well, the toaster was never designed to make martinis. And we're asking these systems to do something that has never been done before. It's important work. It's work that's in motion. But know that at the moment, we do have an incomplete picture of what's going on inside of the county. Next slide, please. So our opportunities are that the work that's already been going on in the county for some years has to do with creating a community health information system that crosses silos in order to answer the question of, well, what does it look like when individuals interact not just with a system, but interact with multiple systems? Currently, we do have a repository of fire and EMS information. We're in the process of integrating information from the emergency room at St. Joseph's. We are also going in and looking at jail bookings in a systematic way in order to create a more holistic and complete picture of what's going on inside of the county and what's not going on inside of the county. And so this is work that is currently in process in terms of integrating information from various systems. Next slide, please. So to kind of emphasize one of the challenges, this is a bit of analysis from law enforcement in terms of what work they consider to be behavioral health related. Again, these systems all exist inside of their own silos, and while they interact, they're never designed to work with one another. When I say behavioral health to a law enforcement officer, they have a very different takeaway than when I'm talking to a mental health professional, than when I'm talking to a nurse at the hospital. These terms are common, but their exact usage and what those mean in pound and ounces are actually really rather different when you interact with these different teams. A lot of what we've been doing over the past several years is not only looking at the hard information, but conducting interviews with what we call the subject matter experts, people that do this work every single day and can give us a read on what information actually means in the operational sense. So keying on the concept of behavioral health, going through and talking to the folks that do that work, behavioral health means different things to various law enforcement agencies, and how the information is coded from the 911 call all the way to that booking at the jail, the release from the jail. There's a lot of nuance in how that works. This one graph is a representation of informational interviews where they're looking at a series of codes that come out of the law enforcement system. It's one thing that I discovered through this process, and I really want to hammer home that the sheer scale of what law enforcement reacts to is really rather dramatic in comparison to EMS or a hospital or any kind of other system. In terms of behavioral health, some of the codes that from their perspective fall into those categories are things like, this also depends on when we're talking about, things like vagrancy, suicide attempts, senile person, mental health issue, behavioral health. When talking to officers that do the work, there's this moment of like, well, things that aren't behavioral health, how do you define them? When you were describing them to people that are not law enforcement officers, I'm like, well, oftentimes people call 911 to call the police specifically because they're looking for a law enforcement response. And a lot of that includes things like, bike theft, boating violations, liquor law violations, littering. These are things that are considered to be infraction violations that are very specific to law enforcement. Similarly, when we get into things that are high risk, high skill from law enforcement perspective, there's this moment of like, well, animal cruelty, arson, collisions, controlled substances. Similarly, when you're looking at things that are mid-risk, mid-skill from the perspective, false alarm, alcohol intoxication, extra patrol requested, assisting an agency. The take home here is that all of these systems have slightly different variables in how they interpret language and the coding of those. And when we begin looking at the entirety of this system, we see a tremendous amount of variance. The question posed here is that we see a graph and we can make the assumption like, well, all law enforcement traffic has these dimensions. And there is this moment where, next slide, please, that may not be representing the entirety of the situation, because when we're looking at information, we're seeing a layering of various policies, procedures, and histories all interacting all at the same time. So just from a workflow perspective, note that we're only looking at information from 2019 and 2020 specific to the Bellingham Police Department and the Sheriff's Office. We also are only looking at a fraction of the reports or the outcomes from information coming from the dispatch system. Oftentimes I'll just refer to it as CAD, computer aided dispatch. That's when someone calls 911, that information then gets sent out to various agencies as their dispatch. Knowing that from a workflow perspective, and we'll get into the workflow here in just a little bit, that law enforcement does not report 100% of their contacts. An individual officer can have, on a weekend, or even in a single day, hundreds of interactions, everything from bike theft to, attempted murder, all points in between. Where there are adverse incidents and where there are people involved, we do get reports, but knowing that on the left-hand side of that blue column, that 133,000 some odd CAD records, we don't have reports for every single one of them. It's a limitation of the information we have available. It's also a dimension of the workflow. From an academic standpoint, it's actually quite interesting to see the intersection of law enforcement and healthcare, because we have other examples like things like demographics. We're talking about demographics at a hospital. When you go to the hospital, they ask you 3 or 4 times, what is your name? What is your birthday? In a hospital setting, the correct medication or treatment to the wrong person is deadly. And so they have very strong workflows of making sure they're identifying the person correctly, as 99% of the time or more. When we're talking about emergency medical services, EMS, in an ambulance situation, it's very hard to confuse which patient is which, because you can only fit one patient in the back of an ambulance. Identification and whatnot in terms of a workflow isn't as concerning as it is in a hospital setting. Similarly, when we get into law enforcement, there's a moment where when people interact with officers, especially if they're being arrested, oftentimes they won't identify themselves or will be reluctant to do so. And so when they get to the jail, of course, they have a series of systems to make sure they have the right person in the right cell. The takeaway here is that when we do look at information, something that we're in the process of sorting out is that there is a tremendous amount of history, a tremendous amount of operational detail, and then just the challenges around getting and reconciling information or to draw meaningful conclusions. Next slide, please. So this is an example of looking at the top center of this color codings of the classifications in terms of informational interviews from officers. And then reading left to right, information from computer-aided dispatch, information from the officer's reports, and then on the right-hand side, information from EMS. So that green section there, we have this moment of, toward the top of that diagram, looking at what is coming out of the CAD. It's reported as a motor vehicle accident with injury and combined response requested. From the law enforcement perspective, this is either the Bellingham Police Department or Sheriff's Office. It's a sister agency, Washington State Patrol, that's what WSP stands for. Looking at the EMS information, they have a patient or two patients, and then one has an injury and one has no other findings associated. They're treated and released per protocol. That lets us know that they were not transported to the hospital. The parable of the blind men with their hand on the elephant comes to mind, where each person has their hand on a different part of the elephant. And when describing it, you get a dramatically different takeaway from the exact same incident. Within the context of looking at Whatcom County emergency responses and services as a whole, everyone and everything is operating as it's intended to operate. There's a motor vehicle accident, there's a response, law enforcement is there, Washington State Patrol is there, EMS is there. But the takeaways from that one single incident are all slightly different, which are extremely specific to the scope of practice and the level of intervention of those services. Similarly, we go down and we see in that red section there, we see a motor vehicle accident blocking with combined response. We do see the traffic-related call there in the middle from law enforcement, and then from EMS, we see a headache or a traffic accident. And the purple section above it, I think, is a great example of CAD is reporting a traffic incident. Law enforcement has driving with a license suspended, obstruction, property damage, and then EMS sees a patient with a headache and or neck pain, and they're treated and released. As we go into these systems and we begin really the nuts and bolts analysis of all of this, it's important to remember that a lot of this is new. And before February of last year, even this level of analysis was unusual to even our system, because traditionally there's never really been an explicit need to go through and evaluate an individual's journey through all the processes that exist inside the county. Next slide, please. So this is looking at the county as a whole entity and knowing that this is very much a flattened version of what does and does not happen inside of the community. There's certain elements that are not included here just for the sake of space and sanity. On the far left-hand side there, and this is work coming out of the specialized crisis programs, there's a need to describe the populations inside of Whatcom County, and we'll get into the details of that here in just a little bit. But in general terms, when people are engaged in emergency services, one of three things is going on. They're having some sort of behavioral health or medical health emergency, they're having some sort of social economic emergency, or they're having some sort of legal interaction, which involves emergency services. As we get into how these systems all interact, know that these systems for law enforcement, for EMS, for the hospital, are all designed to answer the requests of those particular systems and serve those particular needs. What is new is going through and really discussing what that looks like at an interconnected level. Next slide, please. So that folks know, and I'm not sure if everyone is aware of this, there's a website which includes Whatcom Respond, which gets into a lot of the details of work that's been going on inside of Whatcom County since 2014. Back in, I guess I could say the early mid 2010s now, Bellingham Fire and EMS recognized that they were seeing a lot of the same people over and over again, anecdotally. And there was, and when I say several times, I mean to the tune of sometimes over 100 times in a year. And I think if everyone thinks of how many times they personally have called EMS, maybe once, maybe 2 or 3 times in their entire life, several, dozen or, over 50 or close to 100, that's anomalous. And it sparked the teams at Bellingham Fire to assign a community paramedicine, or paramedic, excuse me, to go through and start interacting with folks that they're seeing a lot and trying to figure out what exactly was going on with this particular population. That work started in 2014 with a single paramedic, then has grown to closer to 13 providers across multiple programs. And while it was initially intended to address high utilization, that is folks that are interacting with systems at an unusual rate, there was this discovery process where over the course of time, there was a discovery that people were entering and having trouble what we consider a cycle of crisis. And then as time went on and more programs came online, there was this conversation between, well, what is appropriate and what is inappropriate utilization? On the right-hand side is an expression of those various programs pointed at particular parts of the population and then with their listed interventions. Next slide, please. So when we are talking about specialized crisis programs, there is a limit depending on the available staff and resources for these particular programs. The reason why we're talking about them now is that it's the most complete data set that we have regarding an individual's journey through various services and programs throughout the county. What was once anecdotal, we now have hard evidence and information around the populations, the nature of their problems. And it's been a process that started with, again, a single provider working real hard and still working really hard, and then expanded out into the various programs where we're able to go through and really discuss and look at different dimensions of the population, but we know that we're looking at a really rather small sample of the overall, of everyone that lives here inside of the county and interacts with emergency services. So high utilization for our purposes and for this and future conversations are those that are interacting with emergency services repeatedly without improvement. From the medical side of things, the goal when interacting with a patient is to improve their outcomes medically in every other kind of way possible. When we talk about a cycle of crisis, over the course of a couple of years, it became clear that we were seeing individuals impacting multiple organizations, but they were also not seeing improvement. And so a lot of energy and a lot of care is being put toward these people. Everyone's doing exactly what they're supposed to be doing. EMS is doing EMS stuff, law enforcement is doing law enforcement, the ED is doing their emergency room thing, but the patients aren't getting better. So we're kind of rolling into like, well, what exactly is going on here? When looking at these populations, there's this conversation of appropriate versus inappropriate utilization. For example, if you have a patient who is breaking a window to be arrested so they can get a hold of their medications, it would be considered an inappropriate utilization as someone is using law enforcement in order to get to medical care. Similarly, inside of EMS, there was somebody who had experienced repeated and very painful joint dislocations. And they were calling EMS, I think the record was 14 times in a single weekend. And the providers are, they want this patient to be better and they keep taking them to the hospital and the hospital keeps resetting the joint, but they keep experiencing this cycle of crisis. With the expansion of these specialized crisis programs, allowed an intensive case manager to be involved because they detected high utilization. They're able to go and sit down and ask them, why are you experiencing a cycle of crisis? And the feedback was that they had lost their insurance, weren't sure how to get back, and they needed a surgery, but they didn't want to be away from home for that long. And someone took, an intensive case manager, took the afternoon or three to sit down and get their insurance worked out and get them set up for their surgery so that they could experience relief. And they stopped interacting with EMS constantly. And this, from a care perspective, was a pretty huge success. And in an individual sense, played out the cyclical nature of crisis that we're seeing inside of Whatcom County. In this flow diagram on the left, we have a community, which is ours. They contact what we call a referral organization. Those referral organizations go and send information to the specialized crisis program. They go through a process where they look at a weighted score to figure out if they are a good fit. It is worth noting that the more folks we bump into, the more need that we're seeing, but because of limited resources, we have to figure out, can we have this person connected with services elsewhere in the community, or can we have bandwidth inside of this particular program in order to see them well? It's been something that's been evolving over the course of many years. Next slide, please. From the information we have from these programs, we are able to then look at demographic information because of the workflows associated with law enforcement, for example. You're not necessarily getting a lot of first name, last name, age, the other various demographics because it's not part of the workflow. EMS, similarly, they're much more concerned with the immediate emergency. And so sometimes other demographic information gets missed. It's not something that is wrong is simply an artifact of how that work is done. The reason why we're looking at this information from these programs is because it gives us, at this point, the best view of individuals that interact with multiple systems and is our first stab at describing these populations. For just a point of scale, we know that since 2014, about 707 people have been served by these various specialist crisis programs. And to put a hat on it, last year, EMS saw about 16,000 individuals. And so we're looking at a very small fraction of the population, but it's a methodology we're expanding in order to have a more holistic view of the entire county. Just at a glance between programs, know that GRACE is medical diversion versus leave. It may not be, seem very exciting on its face, but going from having no information to some information, we can see that in terms of proportionally, the population lead is younger than those in GRACE. That makes a tremendous amount of sense because typically younger people have a lot more interaction with the justice system versus older people. This also allows us to look at what we call comorbidities, or things that are going on with these folks that are interacting with various systems. Next slide, please. Looking at folks that have graduated from this program, we're able to go through and list the things that they needed assistance with. This is from all the work that the community paramedics, the intensive case managers have all been doing and reporting. And it's pretty intense work. These systems are difficult to navigate. They're complicated. And if you have the top four are medical and physical health, mental health, homelessness, housing, substance use. Of the population that these programs serve, those are the primary issues. Going from the bottom right-hand corner, 2018 to 2021, what is interesting, and we're still working out the details around, is how the length of stay in these programs went from being about a year, almost a year and a half, and then have dropped as the programs have gotten larger and have more staff and have more connections in the community that allow us to connect folk with services. Anecdotally, we were talking to the sheriff's office, and there's moments where certain patients simply vanished from their roles. And they're like, what's going on with that? It turned out a lot of these folks had ended up inside of the GRACE or LEAD programs for community paramedicine, and they were no longer experiencing a cycle of crisis and stopped bumping into the justice system. Next slide, please. Because of the work we've already been doing with the community health information system, we're able to look back in time a little bit, which is interesting. And it's success we're looking to build upon, but GRACE was never designed to be a legal diversion program. But when we look at the charges for what people that were enrolled in a program had graduated from the program and when they'd been arrested, what they had been charged with, we can then go back and look and see that we were seeing a lot of folks have contact with the justice system, which shifted after they were engaged. But all of a sudden, we know that municipal code violations, court appearances, probation, violation, things like that were kind of proportionally the largest issue for folks before they were engaged. The next being, things like alcohol offense, disorderly conduct, harassment, intimidation, malicious mischief. We know we're looking at a sliver of the population, but this is the methodology that we've been pioneering on the medical health and behavioral health side of things, and are then in the process of rolling out to other parts of the system. Next slide, please. So the main takeaway from this is that the justice system is complex. It is not my original point of training. It is something that I have leaned very heavily on our law enforcement officers to help describe and communicate to members of the community. We know academically and anecdotally that folks that are experiencing crisis interact with the justice system. But when you sit down and really get into how does one enter and leave the justice system, it's really complex. And I really want to stress that this is a simplification. There are so many more nuances to how this interacts with the lawyers and the various courts, and how people can enter and leave the justice system in terms of custody and things like that. This system, like a lot of healthcare systems, but even more so, is really, really difficult to navigate. If you have an attorney, even if you have an advocate, this is really hard. And it's infinitely harder if you are experiencing a mental health or physical health crisis. And that center diamond there, that little yellow guy, is part of the competence determination process, and something that we wanted to address really to kind of emphasize the complexities of all of this. Next slide, please. So the competency determination process is a process of which the court determines if someone is fit to stand trial or not, which already takes weeks and or months. And people can review this at their leisure, but know that if competency is in the process of even being evaluated, this process can take anywhere from weeks to months, sometimes years. And there is a lot of history that goes into why that is, which we'll talk about in just a moment. But there are so many interacting histories and mechanisms, programs, and systems, especially on the justice side. When we are talking about Medicaid insurance, for example, if someone is arrested, they lose their Medicaid. And when they're released, it takes sometimes a week or two for that Medicaid to be, that insurance to be switched back on. And if you're relying on your medications for diabetes, that's a really long 2 weeks. If you are in the process of taking antipsychotics, that 2 weeks is an eternity. And it's one of those moments where there is such an intersection of history, policy, culture that have led to these systems being this way. And it's no particular group's fault because it's no one entity is in charge of all of this. Next slide, please. When we're looking at something as simple as how many people are in the jail system at any given time, there is this series of interlocking histories and policies and funding sources, and all of these things interact that make answering certain questions typically end with something along the lines of, well, it depends. For example, this is looking at Whatcom County and from 86 to 2021 in terms of the overall population. And these red callouts are various points where decisions that happen way outside of Whatcom County have a direct impact on how work is done inside of the county. In case in point, in 1976, the Estelle versus Gamble decision dictated that if someone is incarcerated, the level of care they receive must be at the same level as the standard in that particular community, which in the Pacific Northwest is relatively high. And this is neither good nor bad. It's just simply an artifact of how the jail system operates. In 1981, we saw the ominous Reconciliation Act and the slash federal funding for mental health services at the state level. And it pushed funding to the states instead of the federal level. In 1993, we saw the crime bill that set mandatory minimums and 3-strike provisions for low-level drug offenses, which pushed more people into the system. Going to 2002, the early 2000s, we see the Department of Corrections, they ended supervision for about 50,000 inmates statewide. And this is a part of the parole process, and a lot of that got slashed because there just wasn't the money for it. We also saw a 13% reduction in involuntary mental health inpatient beds across the state, which is already a pretty limited resource. In 2011, you see that large spike in the population because the work center in Whatcom County opened. So you had there's more capacity for people to be inside of the system physically. Going to 2020, the pandemic affected pretty much everything. Jail is not an exception. And so those numbers from the previous years, they didn't vanish. But there's this moment where because of COVID restrictions and limited space and resources, that population then shifted. And so it's worth noting that the Whatcom County facility is accredited through the NCCHC. For those in hospital land, just like the JCO standards, it's kind of the gold standard for medical care in a law enforcement kind of setting. But at the end of the day, the takeaway here is that the county has a budget of around $3 million in year 2021 for medical care that was provided in those facilities. And looking at some of our metrics, we know that on average is about 3,700 mental health referrals in the jail every year. 2021, there was 575 psychiatric visits, 575 medically assisted treatments, has to do with addiction and recovery. 134 people started medically assisted treatment, and the other opiate treatments around 274. It is an operational reality that healthcare is being provided in the jail system. It's just part of it. As we expand our analysis out into the justice system in general, I don't really want to undercut the challenge of not only gathering this information, but making a holistic picture of it, if for no other reason than When I'm at the hospital using Epic or some other large medical record system, electronic records do not take up space on the shelf, and so we don't throw them away. I was doing a study in my time at University of Washington and looking at payment histories going back to the early 1900s for the for the university hospital there. And you go far back into the 1910s, you see people paying for medical services with chickens. In that discipline, it's very normal to keep record pretty much indefinitely because there is an academic interest in going back and reconciling, examining medical records going back that far. Inside of the justice system, it's important to know that Class A felonies, that paperwork is kept for 20 years. Class B, 10, Class C felonies, 5 years. And as we get into the information that we have available at Superior and District Court, there are going to be limitations in what we do know and what we have access to because either it simply doesn't exist anymore or it wasn't kept. Again, it's not anyone's particular objectives. There are so many conflicting and differing methodologies, histories, all coming together when we look at this entire system as one big unit. Next slide, please. Jumping back out to the reason why we're using this approach in terms of information-based decision-making is that the information we have from the specialized crisis program, this is from community paramedicine. And so when we talk about these systems, it's important to remember that we're dealing with individuals. And so the top graph here, red is community paramedicine and blue is EMS contacts. Someone, a male about in their 50s, they're schizophrenic and they've been using meth. They'd been stabilized after being identified as a high utilizer by the community paramedicine folks. They're able to get them in contact with their primary care provider, as well as get them into some counseling to help address their underlying substance use. And we're able to be returned to the care of their family. I mean, that's huge. The individual outcome definitely benefited the system, but for that individual family, that's priceless. And something that wasn't possible for until the community paramedicine program had really gotten up to full steam. Similarly, we see a 40-year-old female with significant alcohol use problems. They generated around $18,000 worth of calls to the system. But again, they're able to be engaged, have their medications bridged, and be able to find success and be housed after experiencing and ending their cycle of crisis. Something that frontline providers talk quite a bit about, I want to convey to the community, is that there are instances where some patients are not going to recover. And part of healthcare, patients live, patients are born, and oftentimes they die. When people get to these specialized crisis programs, there are instances when we're dealing with people that are very, very sick. And sometimes the best outcomes for them are to be enrolled in hospice and be able to die with dignity and not die on the street. The jail has similar issues where, because they become the de facto kind of hold facility, oftentimes their inmates are extremely sick. And because of the regulations, they are providing healthcare, but to someone who may not survive long enough to see trial. It's just an operational reality of all of these systems. Next slide, please. So when we start talking about looking at the impact of these systems, going from the individual out to the system level, the information that we do have available to us, we can look at those that have graduated from one of these specialized crisis programs. We can look at the time shell around the 12 months before they're enrolled in a program and the 12 months after they graduated. And there is no regular metric to that. People come and go from programs on their schedule. It doesn't happen in a very orderly kind of fashion in terms of quarters or things like that. So we know from a statistical standpoint that we won't actually have a complete picture until 0100 hours, December 31st, 2022, on exactly how many people have bumped up against the EMS system after graduation. But with the information that we do have available to us, we know that the reduction, once engaged with services, gets into the 90% range, knowing that we're talking about a very small sliver of the overall population. We know that out of the gate, some of these estimates are rather conservative, where we know that EMS runs cost about $1,400 per run and about $5,200 per transport. It's one of those moments where I want to stress that for emergency services, the goal is never to charge individuals for ambulance transport. The goal is to always make sure people are comfortable calling for an ambulance if they need one. And so sometimes bills are sent, but unlike the hospital, EMS is used as a public good. And because of their funding sources from taxes and from other and being reimbursed from the state, like the emergency room for those that can't pay, that the monies for those aren't necessarily shifted to individuals, though it does cost money, there is an impact. Something that the Respond Whatcom program has been looking at and really getting into is there is no wrong door for entering services. When people are experiencing crisis, the objective is to end that cycle of crisis when possible. Next slide, please. Using the same methodology and looking back in time based on the work we've already done with the community health information system, we can again see the same population that when they're engaged in services, their jail activity shifts dramatically. Back in 2018, GRACE was never intended to address stress on the justice system. But looking at jail bookings going back that far and reconciling that against those that we know graduated from the program back in 2018 even, we can see that when engaged in services, this particular part of the population, their utilization changes. It changes to the tune of 90-some%, talking about that 12-month time shell. So that folks know the jail services and jail booking day information, that's actually really rather complicated. This is an oversimplification, but it's about $55 per booking, 221 days, various fees for it to be in jail per day. Knowing that some of these costs go to the individual, some of these costs go to various municipalities that are prosecuting them. There's a lot of information here that has been simplified for the purposes of sanity and time. Next slide, please. But when we look at the system as a whole, we know this is a pretty conservative estimate. We know that we don't have all the information for the emergency room. There are some programs that aren't represented here. Jail alternatives aren't represented here. And we know that we're looking at, again, proportionally, about 4% of the annual EMS population that EMS interacts with every single year. And it's something that we wanted to, at least on the specialized crisis program side of things, communicate that the monies for these sorts of things, they don't come out of thin air. When people require services, they do get treatment, but then those costs get passed on to the taxpayer sort of thing. And so with the information we do have, we know that for a certain part of the population, when engaged with services, we're able to shift their utilization. And those red bars there really ram home the point that there isn't 100% reduction. Nothing's 100% other than maybe death and taxes. But when folks are engaged in services, utilization shifts dramatically. Next slide, please.
Jeremy, do you want me to go here?
Yes, please.
Okay. First, I want to acknowledge and thank Jeremy for this amazing presentation of data. He spent a great amount of time going back and forth with slides, how best to present this along with Caleb. And so I just want to thank both of them for compiling all of this. That said, we want to acknowledge that this is an overwhelming presentation. There's a lot of data, a lot of flow charts, but it's done on purpose to show you, and I'm sure many of you know yourselves through the work that you do on a daily basis, how complex the system of justice and also health is in your county, but also in the state and nationally. So to step us back out from the weeds, Jeremy and I talk about the weeds in the forest a lot, to bring us back out from the weeds, to remind you the broader question before you today is, what are the health, wellness, and public safety needs of your community? And so to this end, Jeremy's informed you and mapped out the interaction of systems are completely complex in your community, and they're not well understood at the global level. Many of you know what you do day in and day out, but we don't have this broader picture, partly because of the lack of data that allows us to look across the systems. We do know that the work done by these specialized crisis programs establishes that individuals do impact multiple systems, some locally and some not. But really what Jeremy has showed us is that in many spaces, the work that your law enforcement does and the jail is doing is addressing social problems that system was never intended to actually address. And the data also show you, and albeit this is about, I think, if I'm saying this right, 15% of what we know so far of all of the cases or points of contact. But we do know that these programs you have work, right? And they really do decrease the number of long-term stays in your jail. And they also reduce apparently they reduce the costs, the financial costs associated with all of these people being funneled into your jails. So that's what we really, some takeaway points that we do know. This is a very small sample of the population, and you see a reduction of the utilization after engagement, but much more information is needed before drawing county-wide conclusions. And the process of combining multiple systems is new. So this is, Jeremy is just beginning to try and link all this data together. So I think it's important to remember that. Could you do the next slide, please? So the next steps, Jeremy's working on integrating information from the emergency room utilization with the superior and county court outcomes and law enforcement interactions. So hopefully be able to trace cases and people through your systems a little bit more. And then the next slide, please. And then phase 2 will be an attempt to reconcile the findings, review the findings with subject matter experts within your county and maybe outside, I'm not certain, to work collaboratively with other work groups, so start bringing all of the folks into the same Zoom or room together, use evidence-based decision-making to generate informed assessment to decision makers and community, and then generate recommendations that have the best impact on individuals and by extension, the county system as a whole. And then, so those are the next steps, but now we're going to turn to questions and answers. And really the aim is to engage in a conversation. What did you hear? What we sort of your take home? I think actually, Holly, do you want me to jump into the guidelines, Holly? Or are you going to do that?
You can do the guidelines. Just, I do want to flag folks, if you haven't yet renamed yourself, please take care of that little button with at the top of your screen, your own personal screen with the 3 dots. And then Alexis is going to facilitate this next section, and it really helps if you use the raise hand button to speak.
Okay,
So Alexis, anything else you want to say, go ahead. Oh, and turn on your video.
Can you push through the next slide, couple of slides, I think, so the next one. So here are some guidelines for participation that I think Holly developed. I'll just say them. Diverse opinions are welcome. It's helpful to forward your conversation by hearing from everyone. And this is a large call, so we can't do a roll call that I sometimes do on calls where we go through everyone, but we definitely want to hear everybody's thoughts on these issues, even if maybe you think that your sentiment might be in opposition to what other people are saying. With that said, please treat others with a great deal of respect. Even when you disagree, we're all adults and you all know how to have good conversations to move the issues forward. Please attempt to stay on topic and speak to the point that we're focused on in the moment. If possible, avoid repeating ideas. So if somebody already said what you were going to say, just put your thumb up with your raised hand or thumbs up this way. We can do it the old-fashioned way. Try to stay in the room. I like this one. Avoid reading your email. I failed at my last meeting, my faculty meeting an hour ago, but please try and avoid reading your email or texting folks. Let's have a real conversation. I know it's hard to do over Zoom. And then participate in balance with other participants. So I think that means in terms of talking, right? In my classrooms, I'll say 3 before me. So if you've spoken and there's 3 other folks that want to talk, please allow at least 3 folks to talk before you move forward. Okay, and then we have one more slide. Holly, could you show that, please? Okay, so here are the discussion questions. Given what you've heard from Jeremy's presentation, what are the key takeaways that are important to highlight for the needs assessment? Actually, why don't we take the screen share down? I don't think I have the power. I don't have the power. And so we can see each other and just sort of say, out loud or in your, there's no chat, out loud, sort of what are the takeaways that you have that you think are important for the needs assessment moving forward? What did you hear in Jeremy's presentation that stuck with you?
Great. And or any other questions you have. And again, if folks can turn on their videos, that really helps for everybody. So raise hand is at the bottom of your screen. I see some hands up and Alexis, go for it.
Bill, I see your hand up. Please call me Alexis, and I'm just going to go ahead and use your first names too, with no disrespect. Let's go with Bill and then Erica.
Yeah, hi, Alexis. Just actually more of a quick question. Is there any plans to analyze the data from the 2 tribes in the municipal courts as well, or is it going to be limited to the city of Bellingham and the county?
Jeremy.
The goal is to gather as much information as possible. They fall inside of the county, and so the goal is to collect that and analyze that information as well. Recognizing that those systems are very different on many levels in the justice system respect.
Sheriff, I will say, I'm Caleb Erickson, and I will say, Sheriff, that one of the slides that we were focusing in on includes municipal agencies other than Bellingham, because Bellingham's information is a little bit more accessible from Jeremy's perspective, but we're looking at branching out all into the other cities as well.
Thank you.
Erica?
Thanks. Jeremy and I have worked together a bit with Grace and Lead, and Jeremy, all of my data nerd synapses are firing right now. That was such an incredible presentation. And I want to thank you because for those of you that don't know, Jeremy built this from scratch. We didn't have these kinds of systems, and he is giving us access to so much good information that we can use. And I'm sort of curious if there's an opportunity, and this is a big conversation too, but there's so many deficiencies with the current data systems that we have. And I would love to hear about how we could actually change our data systems so they would work better for us. So they would make us a margarita instead of toast, Jeremy. I love that analogy.
I know that there are multiple modernization programs being run by Whatcom County IT right now. To put a hat on it, some of the current systems are old IBM systems from the mid-'80s that were never replaced because there was never a need or a funding to. So there's a lot of work by a lot of teams to modernize systems.
And that might be a conversation you have in the future with a working group, is just sort of brainstorming what do we know about other state systems or county systems that might be possible to bring in, and what will be the funding sources to get them, because they're expensive. Michael, and then Bill.
You, Alexis, asked about takeaways. And I think one of the underlying themes, at least for me, is discerning what the nature and the strength of the relationship is between jail population and community-based behavioral health programs, right? Is there an association? How strong is it? What direction is that association? And one of the things I heard Jeremy say is that Grace was not intended as a jail diversion program, but it kind of worked that way, right? And that's the sort of evidence that we need. Do behavioral health programs, which are good in their own way, also have an impact on jail population? How much, who, anyway, so the takeaway is that there is data, at least for Grace and Lead. I assume when we have the alternative response system up and running, community paramedics, right, that all of these are doing what at least I suspected they were supposed to do, which is why we've been drawing this connection. So one of my takeaways is we've got some data for what I think was my, what I expected or supposed to be true.
Great, thank you for that. Heather?
Heather Flaherty. Hello, everybody. Thank you, Jeremy, for that presentation. I found myself taking pictures, and I'm hoping you can share the slides, because that data is really, really important. I'm curious also about who's not included in the Grace and Lead data, and particularly like who is in the jail that isn't in those programs, what the average length of stay is for those different charges, what are the top charges, because I'm also interested as a community in, are there more opportunities for diversion, especially if we're thinking about like what kind of jail do we need, how big does it need to be? I think it's really important to understand who's in it currently that isn't being diverted. So I'm hopeful that that can be part of the needs assessment data too.
Yeah, those are part of our next steps, and in recognition that Grace and Lead, because of their nature, only look at a very small sample of the population. The goal is to roll out the same methodology, but to as much information as possible.
I think it's a really important point, is that 85% that we don't know of yet, and linking with the Superior Court data, maybe you'll be able to see what the outcomes were those people that were deemed needing of further punishment and incarceration, or were they just released, and what happened? Yeah, great question. Peter?
Thanks, Jeremy. That was really fantastic. You were if you could point out another community that whose data system that you are particularly admiring.
Peter, we're losing your voice and we're missing the meat of your question. Does anyone possibly have an idea of what Peter was going to ask? Peter, we might come back to you if you're, wait, you're
so
moving.
sorry.
There you go.
Okay.
You want to try again?
I'm just looking. Yeah, let me try again. What other communities, Jeremy, are doing a great job with data collection and analysis?
That's hard to say. It's an emerging field. There's a lot of programs like in Colorado, and especially after the summer of 2021, that people are looking at the particular programs in terms of information infrastructure. What we're doing is relatively new. Seattle is launching similar programs, but Whatcom County, we have a unique opportunity that not even 1 million people live here. And in a larger metropolitan area, managing all of that data gets really, really complicated. And so in terms of our region, at least in the North Sound, I think we're a tip of the spear.
Yeah, it's exciting what you're doing here. And I think it's also important. One thing I didn't highlight that Jeremy spoke to was the historical context over years that shape the populations that you're encountering. So both the federal and the state, and then the local policy changes. And then also these shocks to our system, right? So the COVID shock. And then also, if we think about Jeremy and Caleb in conversations raised this with me too, I hadn't thought about it, but the push out from other cities. So the populations you're getting from, say, Seattle or other communities that become expensive or have other issues, people are moving away and into your jurisdiction. So there's this interesting, like, just flow. It's hard to make predictions of what the future will look like, but I think the best way to do it is look at the data of who you have now and are encountering. Heather, is your hand still up for another comment?
If I may, I wanted to add if it's possible to also get recidivism data and an understanding of repeating offenses in the jail over even a couple year trend, that would be really interesting, because what that tells me is, are our programs working for those types of offenses? And one of my big takeaways from your presentation is that the LEAD and GRACE program specifically seem to really work and reduce cost, which is really important. And then Peter asked a great question, I think, about what other communities are doing data well. I have Googled and looked around for different jail dashboards. And I have a couple up. There's one that the Salt Lake County Sheriff's Office has a dashboard, and Lake County Jail has a dashboard. And that is my dream for our community, that we can just see at that population level, like who, it doesn't need to be specifics, but they just have number of jail admissions. Like you said, I loved what you said, going from no information to some information is still better than none, right? So what are the most serious charges? And so there are some nice examples, and I'm sure you know that, but I just want that on the record, that is my dream for our community, that we can see that visually.
That would be interesting. I think there's some jurisdictions moving towards that. Also, to add to that list, Jeremy, if I can, is the reason for them being labeled as recidivists, right? So was it a warrant, or was it like a sentence violation? And was it related to non-payment of fines and fees? Was it related to not showing up to court? Things like that. That detail would be really important. Mike.
Yeah, thank you, Dr. Harris. Mike Healy, the EMS manager for the county, and super proud of your work. Thanks, Jeremy, for that look. And we've been building on this for a couple of 3 years now with just an initial sort of idea, which is, how do we learn how some of this connects it and basically to map it out where all these systems were in the, in our area. And Jeremy's done a great job for this. But some of the input that you guys are talking about now leaves me with, my future recommendation or takeaway, if you will, which is this is a small foundational build for a community information exchange where all of these organizations can feed in and as well as get information out. And so while we're doing this on the back of the Gelada platform, there's an opportunity with this to build this into a bigger informational exchange. We initially referred to this as a health information exchange, but you can see with the complicated spaghetti diagram that Jeremy's put up there, that it really becomes a community information exchange. So I think a future push out of this group would be to understand and maybe figure out how to build this information exchange in the larger community. Maybe not necessarily on the back of Gelada, but some type of connected platform that gets all this information sharing that you're all talking about. So anyway, thanks again, Jeremy. That was great work.
Thank you for that. Michael?
Can I have a turn again so soon?
Sure. Yeah.
That jail population graph is really important, but difficult to interpret. Those are just the raw numbers. And Jeremy, I think, did a really good job of calling out key events in a kind of a qualitative sense that might have affected the numbers. I'd like to see it adjusted in a more quantitative fashion. For example, can you do it based on population? So it's a per capita number. Population goes up, maybe jail population goes up. Similarly, adjusted for crime rates. Crime goes down, as it has been doing, generally speaking, over the decades. Jail population should go down. Those two may cancel out. It may be a wash. But even more importantly, I'd like to see it just adjusted for some kind of societal and sociological factors. Like, can you adjust it for housing affordability indexes or for rates of homelessness? Does it go up and down with those factors? Can it be adjusted again in some kind of quantitative or semi-quantitative way for the availability of mental health services or the affordability of mental health services or the magnitude of community-based services available, right? Because you could tell a story that adjusting for crime, population, and housing, it turns out availability of community-based behavioral health services is the primary factor left driving the jail population. Wow, that would be awesome. I don't know if we can get there, but that's sort of the question I want to ask. So, Jeremy, you got any ideas how we could kind of adjust for some of those factors and see what's left behind?
I'll tell you something to tell you something else. When looking at the EMS traffic over the past 2 years, there is this moment where we traditionally would see about 3% growth every year or so in the overall call volume for fire and EMS. Over the last couple of years, it's been anywhere from 7 to 14. And from an analytics standpoint, and there's other analysts in the county, we have these discussions. There is a tremendous amount of noise, and it gets really difficult to discern what is the signal. Correlation and causation are not the same thing. And so I'm going to set expectations low, is that we can definitely compare those things. But the process of scientifically proving out that X impacts Y to get Z isn't always necessarily there, but I think it's definitely worth examining.
I think one way you could construct that is if you wanted to look across Washington State and jail population over time, and then you would have those indicators, say poverty, percent employed, if you could have percent unhoused. I don't know what a consistent variable would be across counties in terms of affordability of mental health, but it would have to be, I think, to do a statistical analysis, you would have to contrast Whatcom with other counties to see if there's differences. And then, so to get at the real causation, it would have to be a statistical analysis. That I would love to find a grad student to do that and work with Jeremy to do that. But I don't know, Jeremy, it would be kind of fun to think through that, how you could construct that. Yeah. Did that help, Michael? Where'd you go? Oh, there. Okay.
Yeah, no, that was awesome discussion.
Bill.
I just wanted to add on to what Mr. Lilliquist just asked or suggested, but add that the majority of people that are referred by law enforcement for criminal charges never make it across the threshold of the jail. They're not booked into jail. They're issued summonses, or cases are filed with the prosecutor's office, and they decide whether to file an information, and oftentimes, and probably more frequently than not, they're never sentenced to jail in the first place. So I don't know if there's a way to capture that because of the multiple systems, but I think that would be an important consideration as well. Thank you.
Thank you. So look at the difference between arrests
It's definitely in scope, and that's why we're reaching out to the various municipalities in terms of their law enforcement teams and looking at district and superior court and kind of getting a read on what it is we know, and then figuring out that gap, just like how the vast majority of people never get to trial because there's not enough space in the system. That information exists somewhere, but we're in the process of figuring that out.
Yeah, and who knows if it's even automated. Right. Harriet?
Hi, everybody. That was an awesome bunch of data, you guys. That was amazing. Where I go, and I don't know whether you have considered all of this previously, but my brain goes to, okay, there's a ton of data here. What is it really well-defined that we're trying to accomplish? And therefore, exactly what information do we need to answer, or what do we need, what questions do we need answered in order to accomplish our goals? And what's the data that will feed us those answers? Because you can get lost in so many rabbit holes about who makes it into jail and who doesn't. And all, you know, there's a lot of interesting stuff, but if what we're trying to accomplish is to understand what kind of jail capacity we need, then okay, what are the elements of the answer to that? And then look at those data, and just start to get focused about what you're doing with the data. So that may be oversimplified, and you've probably already thought of all of that, but.
No, it's an absolutely fair question, and it's something that comes up a lot inside of statistical analysis. And I'm gonna bore the hell out of everybody for a second. There's a concept called woozling, which is based off of Winnie the Pooh episode of all things, where there's this moment where Pooh and Piglet are following their own tracks in the snow, and they've convinced themselves that a monster's after them. And in the land of statistical analysis, it's very easy to pigeonhole yourself and twist statistics to fit a certain answer. In this initial phase, a lot of the information gathering is simply to get our hands on and determine what it is we know and what it is we don't know. An example from history is when we're looking at World War II between the United States and Imperial Japan. They're looking and they're describing what signal intercepts look like. And you don't know explicitly what you're trying to figure out, what the enemy is doing, but you're trying to keep track of them as much as possible. And the example they give in an old movie is you're living on Hawaii and you know that all the floors are booked. You know that all of the bands are booked. You know that all the cooks are booked. And you might not have a wedding invitation, but with enough peripheral information, you can get an idea of what actually is going on. Part of this initial process is to gather as much information as possible to figure out what it is we can determine definitively and what is just conjecture. The next phase is then being able to answer questions as best we can with the information they have available to make sure that what we're doing is ethical and consistent and replicatable.
And I think that Jeremy's answer is great. And I learned 2 new things, which is really helpful, about Winnie the Pooh and signals. I think also that the presentation today, the one strong message is that these diversion programs help reduce the jail population. So we could, as you know, Jeremy's implying, we could just go straight to who's in jail and what's the utilization rate now, and then up it by 10% for the future. Or you could, and this is what I've been hearing from some of the meetings I've been sitting with people, is that folks are really interested in figuring out, well, do we have to build it at capacity plus some, or are there other ways that you could think about creating a public safety and wellness center that helps decrease the numbers of people currently and in the future who would usually be routed to a jail cell. And so that's, I think the information from today's conversation is very informative in thinking about those future questions. RB?
Hello, everybody. I'd like to echo what other members have said about Jeremy. You did a great job today. I'm curious, there are both state and national programs, like, for example, the Washington State Association of Counties or the National Association of Counties. Are we part of those organizations? And are there best practices that we can tap into where we can kind of see, because there's many other counties out there that are grappling with a lot of the same problems that we are. Are we part of those programs, and what information can we tap from them?
there someone who could answer that question?
Chief Jones?
Yeah, I had my hand up. I could give somewhat of an answer. Repeat your question one more time. I'm sorry, I got sidetracked.
Yeah, there's both state and national programs like
Oh,
the
yeah,
Washington
I remember
Association of Counties.
NACO and Washington Association
Yes.
of Counties. Yeah, right now we're engaged in a peer learning network through NACO. Perry Mowry is leading that effort. We've been involved with the MacArthur Foundation and NACO since 2018, I want to say 2017. Several of us went on several trips to talk about national trends and national data on, for instance, a young adult incarceration. That was our first conversation we had. So yeah, we are engaged with some of those organizations on very detailed conversations and other jurisdictions throughout the country.
Caleb?
So also in response, RB, we as a community have looked at options that exist other than just simply other communities. There are companies called like Recidiviz, which is a more state focused and larger agency that looks at recidivism rates and information gathering across an entire criminal justice system to see what policy decisions have impacts on local community levels and things like that. But unfortunately, it focuses too much on the state level and hasn't really gotten to our small neck of the woods, for lack of a better term. And so we're really, as Jeremy points out, we're at the tip of the spear in terms of these sorts of efforts. And we expect that the models that we're trying to create don't exist other places. And otherwise we would shamelessly try and steal their ideas.
You all are really on the cutting edge with the conversations that I've been sitting in on. It's exciting for me to see how much thought and compassion that folks have in pushing forward. I will kind of pledge to sit down and try and find other examples. I know there's Brooklyn Center City in Minnesota, right after the killing of a young man named Dante Wright by law enforcement officers. Within a month, their mayor took the lead with their city council to restructure their police. So it's more about policing in general and health and wellness. So that's one example, but it was statute-based or ordinance-based within the city. But I don't know collectively of so many folks across one jurisdiction coming together to rethink something, but I'll try and kind of search it up or find a grad student to help me find that. Daniel?
Yeah, thank you. Thanks for the presentation. Great job today. RB, I just want to speak to your question. Do we, what do we do when it comes to looking at other communities' resources? And the answer is yes. Before we started the GRACE program, I went to Spokane, Seattle, Shoreline, and Everett. And the model that most closely resembled what we ended up with GRACE was the CHART program, Chronic High Utilizer Alternate Response Team in Everett, had a 90+ success rate in reducing 911 calls. And we spent about 6 months with the health department, the hospital, the Opportunity Council, and the city administration developing the GRACE team. It was a very complicated process. It was brand new to the community. It was also sort of partially based on the community paramedic model to some degree. And then as it relates to the alternate response team, you saw that on one of the slides earlier in the presentation. That was initiated out of the Behavioral Health Committee for the task force and then moved over to the City Council. And I was able to gather a 7-0 vote to create a line item in the budget for the alternate response team, but not before we looked at the Denver STAR program. We invited Portland and Albuquerque to come to remotely, this was during COVID, to the City Council meeting. So we do examine programs as best we can. They don't always work. They don't always fit neatly into what our needs are. So we modify them to make sure that we're getting the highest utilization out of those programs to create better patient outcomes and reduction in crime and increase in public safety.
That's great. Thank you on that. And I would want to talk to you about what we're trying to do at the UW. It seems like you have a lot of great information there. Perry?
Yeah, RB, great question. And just to add to what Barry and the others had said, we're also, and we'll get more into this information, we're working with the sequential intercept model, which is part of NACO and the Stepping Up initiative. And so absolutely accurate of what Caleb was saying, that there are some entities out there that are doing some very creative things, and those systems bring that together for interaction and additional information. And it's really been pretty amazing to be involved in some of those resources. And to underline what others had said, many of the times when we're involved in these meetings, we're seeing that many of the things that are occurring in Whatcom County are somewhat ahead of some of the other counties that are a part of these systems. So great question.
Any other reflections? Oh, Stephen?
Yeah, thank you. Just to play off Harriet's question on what our real focus is, the name of the group includes needs assessment and gap analysis. So I really appreciated the fire hose that Jeremy turned on us there. And I know that this is going to fit with the next meeting where we're going to get a similar kind of data report on behavioral health, because the lines are blurred here, obviously, between the systems. But I'm just wondering whether the data group that Jeremy, Alexis, and Caleb have sort of spearheaded here are starting to see even vague outlines of what needs in the criminal justice system might be there, or what gaps. I know one of the charts talked about the jail alts and the work center and so forth. Where are there needs within the criminal justice system, if you're seeing those hidden in all that data, or where are there gaps that in terms of the programs or our responses that might show up in recidivism data or whatever that we can start to focus? Are you seeing any of those?
I would say, oh, sorry. Go ahead.
Oh, go ahead, Caleb.
I would say that when we start looking at these systems as a whole, Stephen, we find out pretty quickly that we know we have a pretty good grasp, as Jeremy pointed out in his presentation, on a few elements of what we're looking at. But there are so many data points that we need to know that we'd have to integrate before we could properly answer that question. For example, as the sheriff pointed out earlier, we have a number of individuals who may be arrested on paper or in a non-custodial fashion, and then may or may not make their way through the court systems. We just don't have a real total number of interactions that would encompass. And it's really important to get that metric, because that speaks to the efficacy of these efforts that we're undertaking for the past few years in our community to reduce the jail population. And so the things that I think that, in my opinion, we need to discover are, what's working, right? We already know that things like Grace and Lead and the community paramedic systems are working. What systems don't exist that should, and to the extent that Councilmember Hamill was talking about going out and finding other systems that may work in other communities that could work for us, that's sort of an exploration that's needed. What we don't know, that gap analysis, I have a relatively high view of where all these components fit together, and I'm going up, we need this, we need this, we need this. And so there needs to be some collaboration, cooperation amongst all of our community partners to say, hey, here's the information, here's the way we can get access to it. We can put it in a big pile and start to drill down into the weeds and figure out exactly what those data points mean in terms of, again, efficacy of our systems, what information is there, what we might need to know. I think it was Heather that was asking, and I apologize if it wasn't, but what else do we need to do to make some of our data gathering efforts a little bit more effective when we're talking about tools that were never designed to be used in the way we're using them? What does the redesign effort look like? So, and then I believe somebody else brought up the question of, it might have been Alexis, where do the warrants in our system exist and why do they exist? That's another key element that speaks to the population that is or is not compliant with the overall requests of the court and so forth. So those are the kinds of things that I'm envisioning we move forward with in the coming weeks and months as we start to figure out where those gaps exist and what information we can get our hands on and start to churn through that.
Great. Jeremy, do you want to respond to the question?
Oh, I was just going to say that from the information that I have right now, it's all anecdotal, and Caleb would be the subject matter expert in terms of the law enforcement side. I can speak to emergency services or EMS. There is a lack of facilities at the hospital and with the triage center and with EMS. There are patients that are violent and difficult to manage, and we don't have a really reliable resource currently to manage other than the jail, and there's issues with that. So that is the one common thread. I talked to a lot of different groups and everyone's describing dimensions of the same problem, but that's from the medical side.
Say it, I'm sorry, say it one more time. The gap that you're seeing, the sound kind of interrupted you.
The gap is a lack of, and this is a state and national challenge, involuntary hold for people that are dangerous or the people that are difficult to treat or are combative. It's moments where you have friends that do mental health in hospital settings, in clinical settings, and then talking to paramedics and EMTs, not a very robust system there's no solid or consistent answer to where do these patients go? And the answer to that varies dramatically depending on when and who you're talking to. That is a gap on the medical side that's been described to me multiple times.
Thanks.
Daniel?
Yeah, to back up Lieutenant Erickson to some degree what Jeremy just said, the sequential intercept model will provide a very robust view of where our gaps are, what services we have, what we need more of, and what we don't have. So it's 3 layers. So I just really urge the SAC members to, as best you can, if you're going to, when you do homework, make sure that is at the top of your priority list. It really gives you a great perspective on needs in our community.
Thank you. Erica?
Thanks. You know, from the health department standpoint and talking to Melora, our response systems manager who runs the Grace and Lead program, I know there's a lot of interest and enthusiasm for more programs that can meet the needs of more people. But I also know in talking with Melora that we are hardly scratching the surface of the need with Grace and Lead. So also, like, how do we right size those programs so they can have more impact on the existing populations that could access those services? I think the last time I talked to Melora, there's more people on the wait list who have that really high acuity need than there are currently enrolled in the program. And so in addition to new and more programs at that continuum of acuity, how do we also right size the existing programs that we have that we know work? And knowing who's in the jail and how many other folks could be accessing those services, or a slight drop down in acuity, but still high utilizers would be really helpful. And I'm just making a comment, Jeremy. I know you know all of this in our conversations, but I don't want to lose the thread that we have existing programs that work, and we could also expand those.
Right, you don't want to or need to reinvent the wheel, but is it a matter of capacity? And what would how much money would that look like to increase the capacity of Grace and Lead if there are people waiting? Geez, yeah. Thank you for that. Ms. Arlene? Oop, you're on mute.
To confirm what Jeremy just said, We've been hearing many times from Chief Wendy about the very large population of seriously mentally ill people within the jail who essentially have no business being in the jail. But also they're in the jail partly because there is not the services to look after them and treat them, and which is basically hospital beds. This is a very expensive set of services, but essential. I have had complaints from families about not being able to even, when a child or a young person is having a mental breakdown, they don't have any place to take them. And the same is true sometimes for the elderly. So these are one of the gaps. This is just one of the gaps, which is clear, is treating seriously mentally ill people who fall into the category that Jeremy was talking about. They're either dangerous or they're very difficult to treat, or often refusing medication when they desperately need medication. So we need hospital beds. And I'm not sure where that's going to come from. There's some promise that the governor has a plan and a program for 4 hospitals around the state, but this is many years off. So there's certain things that we actually really do know already, and this is one category.
Well, I mean, and you're hitting, what's happening in your county is the same thing that's happening nationally. The 3 largest mental health facilities in our nation are Rikers Island Jail, Cook County Jail, and LA County Jail, right? So it goes back to that point that folks in law enforcement are really addressing social problems that have not been addressed by this country. Thank you for that. Daniel.
So I'm not quite sure where this fits into our discussions, future discussions included, but one of the major food groups that keeps coming back to is lack of housing, lack of affordable housing, and it really makes an impact on those that are exiting the jail, sometimes into homelessness. So I think at some point we need to have a discussion. Perhaps it might be in the context of discussions with incarceration prevention committees, just a briefing on the current housing resources that we have, up to and including the Bellingham Home Fund, which is Bellingham only, it's not the county, and then $1590, which were passed last year. It's an additional $3 million in the city and $2 million in the county. So at least we have a handle on the challenges, the structural challenges that people face that either may have a cause for them to enter the criminal justice system, or it affects them upon exiting.
Great, thank you. Other thoughts or questions? We've sort of built out this list of other information that you might need. I've heard about sort of what is the capacity or what could be the capacity of LEAD. And I'm just having a brain, I can't remember the other organization.
Grace,
thank you, I'm sorry. What may be happening on the indigenous lands or the tribal lands. I've heard about sort of the homelessness needs, information about warrants, right? Because that's a big piece of picking up people on warrants. Why are they being picked up? Are there reasons that maybe they don't necessarily need to be incarcerated because of the violation? What are other buckets that you've heard, Peter?
Since we're talking about large structural issues, it hasn't come up today, but workforce, like we need a pipeline of behavioral health workers to solve some of these problems and to prop up GRACE and LEAD and the other programs.
Yeah, definitely. What do you, once people are in those programs, then what do they do when they exit? Harriet?
Thank you. Peter, for that. It's been in the back of my mind for the last 2 sessions. Is there any kind of a state level effort to address the workforce shortages? Because I know it's nationwide for sure. Clearly, it'll be statewide. Is there money available, and are there programs, and is anybody doing anything structured about it?
Perry, do you know? Oh, great.
Yes, thanks, Dr. Harris. There is, Harry, it's a great question. And there's both state and actually region processes that are occurring focused on the workforce gap and incentivizing that process and bringing funds in to address that process. So thankfully, that is in play.
Daniel?
Sorry to be such a chatty Cathy today, but I've got some ideas here. One thing I think that we need to address is treatment options for newish street drugs like phenyl, propanol, methamphetamine, which is horrible to say the least. Fentanyl, carfentanil. We have Suboxone, and we have treatment options potentially. And I understand that Vivitrol can work on the P2P meth that's on the street now, but I don't think it's FDA approved. So that is absolutely a causal factor for some crimes, whether they be property or assaults. But it definitely needs to get into the mix. And then inpatient treatment services that would include substance use disorder, in addition to the mental health facilities that we have, the 4 that we have in Washington State.
Great, thank you for that.
On my list, I have looking at the jail population and in combination with a number of factors: housing, cost of housing, overall population, percent employment, cost of healthcare, and other services.
Doing that type of analysis, maybe within your county or across all counties in Washington to see where Whatcom fits. Yeah. One question on my question list is what capacity? I mean, I think that the 36 people on this call today could solve the problems that we have, right? But in reality, what do you all have control over moving forward with your committee, with the tasks that you've been charged with? What do you have control to do? And what's the capacity to create that solution? Again, I'm trying to get the forest, get us out of the weeds a little bit right now. We know what we need, and that's hard, right? We know we need jobs. We know we need housing. We know we need substance use disorder treatment, mental health facilities. But what do you, with your charge as a committee, what do you have control over doing in the future? Stephen.
Well, this is one of the things I've been thinking about during this really rich conversation is the Stakeholder Advisory Committee has quite a targeted, time-limited scope of work. And what we're describing, whether it ranges from Mike Hilly's great suggestion that we have a community information platform to building up workforce and other systems changes, but those are many year projects across institutional settings. And so I think one of the things we have to discuss, and it may bounce back to the county council and Barry, is how do we segment out all the work that we've touched on today, and how do we parcel that out? Because I really appreciate the sense that SAC members now are starting to get about the complexity of this, the multi-agency kind of settings for these changes. But the recommendations that are going to come out of the SAC are going to have to come out pretty soon, and they're going to be focused on a certain part, but not all of this. And a lot of it might bounce back to the incarceration task force. A lot of it just might rest with the county council. But we ought to be planning that larger, longer term sequence of steps that we've already identified.
So I'm a professor and I'm not scared of silence, but I think I heard a call to your city council members, and I think there are a few on the call.
Yeah. I think the way we get there is how we're proceeding. We are building this airplane while we're flying it, and it's kind of exciting. I think using the task force is going to really help us be able to take all this conglomerate of information and policies and everything we're going to be discussing over the coming months and focus it down to what those needs are going to be. What our output is going to be a report or a needs assessment that's going to talk about capacities. It's going to talk about location. It's going to talk about services. It's going to talk about gaps. It'll be a holistic report of all the findings that come out of this committee's work. So what I'm hoping that we get is a really good consensus on those important factors, which are location, the size, the services, and kind of what the facility needs to offer and what we need to look for the community services to offer, and how we meld those two things together to make an effective holistic program. So that's kind of what I see, or how I see our work.
Oh, Wendy?
I would very much encourage that probably starting sooner than later, we start getting state representatives and senators involved, because a great number of the issues that we're talking about are larger than this county can handle. The larger psychiatric hospital in Washington State has reduced civil beds, mainly because they need so many that are coming through the criminal justice system. But Washington has never done an overly outstanding job as a state as far as providing services for folks who are seriously mentally ill and have not necessarily recognized that. They also have a tendency to silo money, so it makes it difficult. A great number of our offenders have issues of mental health, substance abuse disorder, cognitive ability in a varying amount of time, undereducated, yada, yada. So they're not just one thing, they're multiple. And allowing systems to interact is going to be critical. Now, that being said, I don't think we should stop anything that we're doing now, but we need to start looping people in, because otherwise we can fix some of the folks we already have. And then what we've started really seeing in the past couple of years is folks coming to the area because they know they can come here to get help. Mm. And so that means that we're helping the ones we've already got, but the jail population is now starting to go up again. And it's not, I mean, Grace, LEAD, all of the programs are doing a spectacular job. And so logic would say those numbers would keep going down, but they're not. They were artificially suppressed with booking restrictions and that type of thing. Our average length of stay is getting longer because the type of people that are here kind of get stuck. So it needs to, I think that this is like planting the seed and developing the seedlings, but we need to also start putting some feelers out to some of the larger systems. Just a suggestion.
And Wendy, thank you for that. I wrote that down about a half an hour ago. I wrote state legislators and I circled it. So I totally picked up on that as well.
Thank you.
You know, it might be worthwhile to find colleagues in other counties as well, to create a coalition across the state, to ask the state to address some of these issues too. Kristen, I saw your hand up and then down. Would you like to speak?
Well, yeah, I heard Barry mention jail location, and we didn't really talk about that today, but it is an important factor in our decision making here with the Stakeholder Advisory Committee. And I'd like to know what considerations have been tossed around, if any, about location. I'd like to be updated on that. Is there just any quick thoughts about the various locations at all yet, Barry, since you mentioned it?
I think right now there's no firm discussions on that. There's capacities being looked at, like out at Division, what kind of capacity that land might offer. So it's being looked at from the facilities at the staff level, but we haven't really encompassed it into this group in this planning team yet, but it will be coming soon. Because you're right, Kristen, it is such an important piece of this discussion.
It absolutely is. It's the elephant in the room, basically, you know. Yeah.
Great, thank you for that.
So,
Oh, sure, Holly.
can I think John, yeah, just John Muchler, have you been trying? I see your hand coming up and I'm wondering, no, okay, great, go ahead. So I think Arlene's next, yeah.
Arlene? Oh, you're on mute.
There you go.
I don't think I can't do it. There you go.
Yeah. Back a couple of conversations to where do we need to start? A lot of what we're talking about is we know a lot of things that we need. We also know we don't have the funding for it. And so the funding piece is gigantic. And my feeling is go to the top. You know, why don't we engage the President of the United States? He's got mental health issues on his list of things to do, but we could prompt him and beg him and ask him to get going on it, because much of what we're wanting is on the scale, such as housing, that really needs federal funding. And the hospitalizations and so forth. These are really major issues. But aside from that, the state is the next level of funding that's important. And we have a number of legislators in the Northwest that are very supportive of all the programs that we're talking about here today. And they work in concert with one another and with the other legislators. And so I have faith that we're going to get support for the programs that we recommend. The past experience of the task force has been just to make recommendations, but a lot of the recommendations have been put into action. And in particular, I'm thinking about Eric Ritchie, who said when he ran for office, he was going to make certain changes in the criminal justice system, and he has gone ahead and done it. And there are other areas where we've made recommendations and changes have occurred in mental health programs, but so not enough. That's all I can say about it. It's wonderful what we've done. And I'm proud of our community for what they've done. And it's inadequate. And this is our opportunity to make it really robust and cover the waterfront of all the needs that we have. And I believe that we can do this. But you have to be willing to fight really hard and to come up against whatever resistance there might be to putting more money into our mental health and supportive services, because everybody sits on their piece of the budget. We all know this. Mm-hmm. And so let's just, everybody use the influence that they have to make this happen. And I think that, this program that we're doing is very exciting and very hopeful.
One of the things that I remember from a high school teacher writing a paper was that you think of it as an elephant and there's different pieces. And I think you have to be really careful on what piece of this is crass, but how to eat an elephant, and you have to eat it piece by piece. So you have to think about what you're eating right now and what's in front of you. And what's in front of you is figuring out what is the specific needs assessment, what can you measure within your current jail, and then how can you envision and provide recommendations for this new facility moving forward. These broader social problem issues, I'm sorry, but you all aren't going to solve them in the next year or two. And so maybe it's some of you need to break off and figure out how to get the tail, how to get the legs of that elephant, or maybe it's the whole body of the elephant, and work with the legislature. But I really hear Stephen is pushing you all to think about what is the current forest in front of you and how can you stay focused on that project. But all of the issues you're raising are just amazing, but you're going to be in this battle for the rest of your lives. We are all going to be in this battle, commitment for social justice and helping our fellow brothers and sisters. That we're going to be doing forever. So anyway, I just want to say that nugget there. Daniel.
Yeah, Doctor, I agree 100%. I share the vigor of Arlene's statement, and I totally support that. But we face these issues on the incarceration prevention and reduction task force because these problems are societal and they're big. And so how far back do you go? Do you go to prenatal? I mean, sure, we could do that. On the task force, we can talk about those things. On this committee, no. Our goal is to come up with recommendations for a work product that will then go in front of voters, that will be taken by a campaign theoretically, and go in front of voters next November, not this November, but next November. Having done a number of different political campaigns in Whatcom County, time is a precious resource, and we don't have infinite time, so we can't fix everything. I would recommend that we, come up with considerations of interventions and treatment on behavioral health. So maybe that's some of it's pre-arrest, definitely upon release from the facility. We have to figure out a facility versus within that. So what do we prioritize? And I think that's what I heard from voters over the last several years is that they really want those investments in treatment and behavioral health. And I think that we have an opportunity to do that, but we have to put parameters on what we are doing because we don't have infinite time or resources. And Arlene, I totally agree with you, but I just think that we're kind of boxed in here a little bit.
Yeah. Thank you for that. Atul?
Hi, and sorry for not having my video on earlier. I had biological needs. I needed to feed myself, so I was able to pay close attention to the presentation and the questions, but and still feel my body's needs. But anyway, I wanted to address the issue, the presentation and the data. For me, really was very helpful in asking questions about what's the data that we would be ideally beneficial to do a community needs assessment. And the community needs data comes not from inside the incarceration system, it comes from the community and the actual individuals living in this community who are potentially headed in the direction of incarceration or headed in a direction that could lead to a series of dominoes that lead them into near incarceration even. And I'm just wondering about what methods do we have of quantifying that? And how much energy are we putting into quantifying that? Because what we've learned from the community in listening tours and by recommendations by international and national experts is the importance of understanding what the community's needs are outside of or prior to their exposure to the incarceration system. So I wanted to bring that up because that's always been my focus, or I should say at least for the last 6 months that I've been seriously making effort to understand this important problem that most of y'all know a lot more about than I do. So one thing I did benefit from in the data presentation is how even by looking inside the carceral system, how many clear examples there are of ways to pick away at the population of the jail. And that's very an optimistic discovery that, and I look forward to, as I did the first meeting, watching this meeting 2 or 3 times, and probably Jeremy, your presentation maybe 5 times, but anyway, because it was so dense. So I appreciate the opportunity to speak about this. Thank you.
Great. Does anyone want to address the question about community needs assessment? Has one been done, or is it one plan? Is this within the scope of your task at hand?
Barry, what about the listening session?
Well, what I was going to say is, I guess, depends on how you define community needs assessment, because actually that's what this process we are speaking of right now is. This is a community needs assessment that you, as part of the community and stakeholder advisory committee members, are a part of. Now we're going to be going out to the broader public for input as well. We are conducting a community needs assessment, in my view.
Wendy?
I think we may be able to tap into some information the health department already has. I know the behavioral health folks do regular needs assessments. Sometimes it's aimed at juvenile drug or alcohol use. Sometimes it's open sessions where people can come and speak to what it is that they feel that needs to be supplied for the community. I'm not sure when the last one of those were done, but I think they're probably floating around the health department somewhere. Perry, Jackie may have a sense of where some of those are stashed. I'm not sure. I know I've participated in a number of them as parts of the different boards. So that might help move that forward a little bit.
Heather, do you have some thoughts?
I have a kind of a running library of community reports, and I'm happy to share them. For behavioral health, the most recent ones I've seen are, of course, for our youth, a little different, but still important. We have some, and the COVID impact assessment that the health department just did shows a lot of need with behavioral health. And the annual youth survey, new results just came out, pretty alarming. Also, the Whatcom County Behavioral Health Fund does an annual report that gives some summary of what's going on. The listening tour is important, the jail listening tour rather. In 2016, there was a Whatcom County Behavioral Health Facility Planning report, and I believe that was included in an early email for the SAC group from Barry. And then in 2009, that's the last report I see that was a behavioral health planning report globally. So I can send you links to this library. It has also reports on housing, economic opportunity, and everything's intersectional. I get that. But just to answer that question about needs assessments.
That's great. Thank you for that. It's tons of information. So we're coming up to the close of the meeting. I know Holly has one last slide to share, and I was
going to follow up with Heather unless Kathy or someone else wants to provide that to everybody. So.
Yeah, I think, let me just say that I'm thinking also, Erica, you might have some other stuff. I'm thinking of the community health assessment, et cetera. So why don't we'll put on our Justice website, let's create a folder or something so that as people, think of good resources that provide that larger context about what our community needs, and then other data or information that might be relevant. We can start just having that context. So we're just about to wrap up. I think, Dan, did you have one more comment you wanted to share before we shift gears?
Oh, just the city periodically does surveys of a few thousand residents, and those might be helpful. So maybe just put that on the list. I don't know when the last one was done, but it is germane to what we're talking about.
Holly, can I just summarize real quick the meeting?
Yeah,
just sort of 4 points. One is that we're very clear that there are a host of complex issues and structures and spaghetti lines that people fall into. To think about how you're going to shape the next public safety building or system that you have. 2, there's a host of data needs, and we've created a really good list of that. And I think Jeremy and Caleb will start working on that and figuring out what else they can get access to. 3, there's a clear need that you all talked about to address social problem issues from substance use disorder, homelessness, education, but you all need to figure out what can you really address with your scope of your project. Maybe there's a break off point where folks work with the state, but in some way, can this new facility address some of these social problems that you're talking about? And then the fourth thing that I really heard, which was exciting, is that this is an exciting moment for you all. It's a really neat opportunity to look at, not to feel overwhelmed by the weight of the elephant, but to think about how you can parcel, again, really crass example, but how you can parcel it up. You all have a really, really exciting moment to do this work. And I'm excited to listen in and hear all of your ideas. So thank you for letting me facilitate the meeting, and I'll turn it over to Holly and your last slide.
Great. Well, first off, Alexis, what a treat and a gift to get to have you at this meeting. So thank you. That was awesome. And again, Jeremy, amazing presentation. Caleb, I know you were working on it too. So thank you all so much for your time. It was fantastic. I want to thank everybody for being here today. We're going to do the last slide, and actually I'm going to turn it over to Barry. You get to wrap us up. But I did want to mention that I don't know if you all remember, but one of your tasks, one of your responsibilities as a member of the SAC was to talk to 3 people, remember this, who you can just sort of share what you're learning and get their feedback. So this doesn't replace a community survey, but it's part of just informing our thinking. So as you reflect, here's what I'm learning, here's what I'm thinking about, and you get more input, that'll be really helpful. So I'm going to just encourage you again to do that. And probably by our next meeting, we'll figure out some kind of a system so you can record what you learn. So that was my little piece. Barry, are you happy doing that next slide then?
Yeah, if I could see it.
Yeah, so Jackie, thanks if you could put that up. Great.
Okay, so this is a big one, this joint behavioral health meeting that's going to be coming up on April 19th, 11:30 to 1. You all are invited to that. We were going to invite you as listen only, but we decided this morning at our steering committee meeting that this conversation is so important and so fruitful that we're going to invite you all as panelists to that meeting, so you'll be able to participate in the conversation. So that's an important one. And then SAC meeting number 3, which is our behavioral health and gap analysis, will be on June 8th from 2 to 4 p.m. So with that, I have nothing else. Holly, did you have anything more you wanted to touch on?
No, that was it. I think we've got it. And look at that. We're ending on time. And again, just Alexis and Jeremy and Caleb, thank you all so much. And a phenomenal session and such good thinking, everybody. I think we have every reason to be optimistic at this point that we're going to come up with some good stuff. So anything last comment?
And I want to echo that. The great presentations. Thank you, Dr. Harris, for being here. Alexis, your work is so important. And Jeremy and Caleb, and I know Melora was involved as well. Yeah. So again, we thank you, and thank you all for coming. And we are adjourned.